Going to go ahead and introduce you. Welcome everyone that's here. My name is Judy Booley, past president of WMCA. We have Lindsay here, and I'm going to let her talk a little bit about herself and about her presentation on navigating mental health referrals. So welcome, Lindsay. Thank you for taking time out of your day to do this for us.
Thank you. I'm glad to be with you all. My name is Lindsay, and I am a licensed social worker, but I don't do clinical work anymore. I used to do clinical mental health work years ago, but for the last 7 years, I've been in this role as a referral relations professional at Pine Rest. So, in my role, I'm really connecting with partners like you who are on the other end. So, I like to think of most of our services at Pine Rest are, when people walk in the door to when they leave and discharge, and we have a plan for them. I'm kind of the bookends of that. So, I like to be talking with folks about what happens before someone gets to us. And then, sometimes we're talking about what happens after they've been in our care and how you can connect with them then. So, I'm excited and passionate about system change and things that can help lots of people. So I love to talk to groups like this. And I hope that our conversation today gives you some fresh perspectives on mental health. I'm sure some of it will be a repeat for some of you, but hopefully you learn some new things, and it just kind of grounds you in what to do when someone needs help. So my objectives today for you to know how to identify kids with mental health disorders, also know what mental health services are available, and then also know what to do when a kid needs help. So I just want to start out by talking about this, that mental health impacts all of us. If you would play along with me here. There's an activity I usually do when I present to people in person, and we can't do it quite the same, but let's imagine it. So if you would close your eyes for a moment and imagine we're meeting face to face today. Perhaps we're gathered around tables. Maybe there's 5 people at each table. Can you see it? Can you picture some faces? Now, according to the statistics, at least one of those people around your table is living with a mental health disorder right now. You can open your eyes. So that's true. 1 in 5 adults, and same 1 in 5 kids, will experience a mental health disorder this year. And while we're here with our professional hats on, we want to recognize that mental health impacts everyone. And most of us have loved ones who are facing a mental health condition right now. We might not know who they are or what they're dealing with, but we have people we love who are dealing with this. Several people here are probably in therapy, probably on medications. Many of you have parents, kids, siblings, kids, close friends who have been patients in our hospital, and maybe even you have. So I say that because it's important that we remember when we have this conversation today. I hope that I'm sensitive to those experiences. And also that when you have situations with colleagues and you're talking about what to do about a kid and maybe processing a situation, that you remember that you don't always know everybody's story. Sometimes when I give tours, I will have somebody pull me aside and say, my daughter was here, and they'll tell me their story. And so we just don't always know how it impacts everybody. So I hope our time together not only equips you professionally to handle mental health crises and to help people, but also to pay attention to your loved ones, your friends, your neighbors. How are people acting, and look for signs that they might need some help. And I just want to also mention that these conversations often take many times. So whether it's a student or whether it's your friend, think of yourself as a seed planter. It's not a failure if you talk to someone in a family says that they're not open to therapy, or you talk to a friend and they're kind of not recognizing their own mental health symptoms. That's not a failure. It's a seed. It's a seed that's planting. And hopefully then when they go to their doctor who says something, or their spouse says something, or whoever says something, that then that's another seed. And hopefully those build up to some momentum in getting services. We know that sometimes this takes a while. The mental health stigma can be real. So let's start at the beginning. What's a mental health disorder? So NAMI says a mental illness is a medical condition that disrupts a person's thinking, feeling, mood, ability to relate to others, and daily functioning. And the Department of Health and Human Services puts it a little differently: serious deviations from expected cognitive, social, and emotional development. So I think that I'm probably not the only mental health professional who has looked back on my elementary school years. And, I can't diagnose folks, but I can certainly look back at those kids that I thought of as weird or strange. And that's not always the case with mental health symptoms, but sometimes it can be. But those kids who had a deviation from the norm, right? They didn't quite follow the social rules. They maybe didn't see the social rules. Now I can look back and say, oh, I bet there was something else going on there. And I think sometimes we forget about trauma too. And so trauma is part of this all, is people have often experienced things that can be part of their story, that bring them to having some of these deviations. So now I'd like to just talk a little bit about symptoms. And so if you could use the chat function to share symptoms that you think of when you think of when a kid comes to you and you go, okay, yep, that's a referral for mental health services, or just kind of the things that you pay attention to that you would know, okay, so this person probably has a mental health disorder. What are the kinds of things that you pay attention to? And Judy's going to help us here by reading some of these off.
So we have self-harm, peer interactions, anyone else would like to share so we can get kind of a nice rounded here we go. Great. Unresponsive to school, attendance, work, severe mood changes, defeatist attitude, anxiety, just even to the point where they can't sit in class.
Yep. Yeah, those are good ones. I know that you have a lot of lived experience here. So this next slide here, I'm gonna put up, but you've already hit on several of them. I'm not gonna read the list because I think this is stuff that you generally know and you can look over it. But I think that some of these are more obvious to us than others. And a couple that I'll just hit on. I think that with kids, a couple of these tend to be a bit more obvious or more present more often with children. And so with kids, depression often can look like that irritability piece. So if you have a kid who's really, especially young children, elementary age children, if they're having a lot of anger issues and irritability, often that can be a sign of depression or other mental health disorders. I also want to mention along the suicidal thoughts, of course, those can range from having from being passive. It's on a spectrum here. So it can be as passive as I just want to go to sleep and never wake up, right? Or I just wish I never had to come to school ever again and I don't want to go anywhere, like that. Some of that stuff can, there's all kinds of signs. So suicide assessment is another presentation within itself. And I'll talk more about that because we actually do have a suicide assessment training coming up. But just want to remind you that there can be real passive kinds of things as well as more active plans. So the next slide here really points out that the physical symptoms are probably thought of less often, right? But I think that this goes to show that a lot of times, I think there's sort of, even with adults, there's sort of this stereotype that like people are going to like go, like if they're feeling depressed, they're going to go to their doctor and they're going to say, oh, I feel really depressed. Can you help me? And that's just really not how it works. I mean, but with both kids and adults, they need a professional to name what they're going through usually. Even mental health professionals themselves will tell you that when they experience it themselves, it is hard for them to see that that's what they're going through, even though they might be an expert in it. So some of these things are going to present sometimes before or alongside the other symptoms, and these ones tend to be more socially acceptable. So a kid, especially younger children, again, might not have the language for anxiety, but they might have the language for saying, I have a headache, right? So with little kids, especially, pay attention to any of these changes with physical symptoms. And also, when we think of panic attacks, I think it can be really helpful to do some teaching with kids and teens about what are the symptoms of a panic attack, because it can be really scary if someone's having a panic attack and they don't know what it is. They don't know the name for it. So those are all some things to think about and to be paying attention to, and perhaps doing some education with students. So this comes from a study with parent-reported diagnoses of kids aged 3 to 17. And of course, these numbers are not 100% accurate because parent report is not the most reliable form, but it's also likely that these are very low numbers in terms of representing how many kids actually have these disorders, because parent report is reliant on diagnosis. And we know that most mental health disorders are underdiagnosed. So oftentimes they're not identified when someone has it. But this is a good kind of overview of the typical most common disorders we're going to see in kids: ADHD, behavioral or conduct problems, anxiety, depression, autism, and Tourette's. And it's important to remember that often these are co-occurring with each other. So from the study, about 40% of the time they had 2 of these or more. And then there's also substance use, right? So that can go hand in hand with any of these. So we talked about the 1 in 5 number. So when we talk about 1 in 5 live with a mental health disorder, 13% of youth age 8 to 15 live with a mental health disorder that's actually severe enough to cause impairment in their day-to-day life. That's a pretty big number. And when you look at teens specifically, that's 21%. So again, we're back at the 1 in 5. So they're having significant interference in their day-to-day life because of their symptoms. And then we need to remember that suicide is the second leading cause of death for teens. So let's drill into that a little bit more. This is from some research specifically done in Michigan. It was a couple years ago, 2013, but it was over 4,200 high school students from 90 schools in Michigan. And you can see the green is sort of the Michigan total. So that's probably the most helpful bar to look at. But I think it's helpful to remember that, again, suicide is on a continuum. So there's, everything from actually attempted suicide, and then a suicide attempt that requires medical treatment. That's on one end, all the way to feeling sad or helpless. But that second one, seriously considered attempting suicide, across Michigan is 16%. There's actually another study in Kent County and Ottawa County in which they show that 8% of middle school and high school students had attempted suicide, 8%. And then 20% had reported thinking about suicide. So 1 in 5 had thought about suicide. And I just want to say a note on language here. I think I'm a big believer in language being important, and sometimes it can be hard to keep up with language as it evolves in our work. And even I slip up with a variety of terms sometimes, but I have been shifting over the years to instead of saying committed suicide, because that can sound kind of accusatory and be painful and hurtful for families and for people who are experiencing mental health symptoms now. We talk about people who died by suicide. So if you are, having these conversations with each other, the language can be helpful. So saying someone has died by suicide is a more tender and sensitive way to talk about it. So in any given year, only 20% of kids with mental health disorders are identified and receive mental health services. So that's a big number. So when we're talking 1 in 5 has a mental health disorder, but only 1 in 5 of those, 1 in 5 of those is actually getting identified and getting to services. So some of this can be really sobering, a bit of a downer, but I hope that we can focus today on, we'll get to what do you do? And I think it just all comes back to how important your work is. So delayed treatment is just all too common. Half of all lifetime cases of mental health disorders begin by age 14, and there's often long delays. So the quote below shares the number that the average is 8 to 10 years between onset of symptoms and first treatment. And that's an average. So for anxiety, we're looking more like 20 years. 20 years is a staggering number of years for someone to live with anxiety before they get professional help. So the second quote, I like that it points out 8 to 10 years for a child. Think about that critical developmental years in the life of the child. When I think about this, I really picture not just the child, I think about how it impacts the mother or the father or the grandparents or whoever is caregiving, how it impacts the teacher and the peers and the siblings. Oh my, there's so much impact, right? And then I think about that kid. I think about all the ways that they've learned to deal with what their symptoms are, and probably not in the best ways, right? How do they try to cope? What habits do they form to deal with it? How are they going to possibly undo those habits later? We know that research indicates that the amount of time between the onset of symptoms and first treatment is a predictor of the success of their treatment for the rest of their life. So to say that differently, the longer it takes for someone to get to treatment from their first onset of symptoms, the less likely their treatment's going to be effective. And so it's urgent that people get to help soon, right? When they have these symptoms. So the impact you know this, right? This is stuff you see all the time. It can be trouble at school. It means not coming to school sometimes. They're having conflict at home, conflict with peers. Sometimes it can lead to legal issues, substance use, and of course, chronic health conditions are linked with this as well. And then what I think is really interesting is the research is clear that not only does it impact a youth during their youth years and risk for all kinds of things, they are at higher risk later when they're an adult. They're at higher risk for poverty, unemployment, using our healthcare system a lot, and having a mental health disorder. So this is where you come in. This is where your job is so, so important, right? Because you're seeing these things, you're noticing these things, you're the person they're coming to when these things are happening. And the work that you're doing to identify kids who need help and get them to the right place and plant those seeds with their parents and with the kid to help them be open-minded to care and treatment, that all is not just essential, but it's life-saving. So here are some of the tools that you could use. The patient health questionnaire is a tool that's used broadly, but this is the PHQ-A is specific for adolescents 12 to 17. That's a depression screening tool that you could use. The CAFAS, Child and Adolescent Functional Assessment Scale, is something that we use in our work at Pine Rest, and that's a way to assess day-to-day functioning across a variety of life domains. So that could be helpful to you. But really, you don't have to be the expert at all things. And we have psychological testing, and we also have therapists and that sort of thing. So, if you are thinking a kid is displaying some signs that maybe you think they have ADHD, maybe they have autism, something like that, a referral to psychological testing is a good idea. And we have our psych consultation center, and I have actually gone there with my son who has ADHD. So I can tell you myself that I've had a very positive experience going through that assessment process. It's so helpful. And I also want to point out, because of that comorbidity, that 40% of the time there's two things going on. Often treatment's not working because of that. And so if someone's identified as having anxiety, but they're not identified as having something else, then that anxiety treatment's not going to be as effective as if they figure out what the whole picture is. And so psych testing can be really helpful in some of those more complicated cases as well, to tease out, okay, is there something else going on? Sometimes ADHD can be, often they're misdiagnosed, they can look similar. So that's an example. Of course, you can also refer them to primary care to help with maybe meds and just management. So it can be helpful to kind of do an overview here of the levels of care that we have at Pine Rest. And we have residential services. We have our psych urgent care, which actually is just for adults right now, but we hope someday to have one for kids. We'll keep you updated on that. But these are the general levels of care when we talk about a referral to mental health care. Outpatient, partial, and inpatient, and most insurances pay for these. So I think it can be helpful to just do sort of an overview. So outpatient is what you typically think of as therapy, but also we have groups, we have all kinds of different ways that some of them are educational groups, some of them are, like a 4-week or an 8-week session kind of thing. Others are a rolling group. So there's all different things available. But traditionally, if you think of therapy, once a week, sometimes twice a week or every other week or once a month, whatever that person needs. And that really is helpful to giving them the skills that they need to think differently about things. And then down at the bottom, you can kind of see the other services. We have substance use services as well. And then ACT and TMS are treatments that are generally used for adults. But those are for people who have treatment resistant depression as well. So partial then is a level of care that's kind of between outpatient and inpatient. And I like to call it our best kept secret, because if there's one level of care people know about, it's partial. Partial is a wonderful level of care, and we do have a program specific to kids and adolescents. And it's, for those people who are really not functioning well in their day-to-day life. So for kids, often it means they're not going to school, or they're going to school, but they're in your office most of the day, that kind of thing. It's good to catch folks as early as we can, right? So if we can catch them at therapy, great. But often people who have regular mental health needs might be going to therapy regularly and still have times where they're having some extra trouble. And so partial is a really great intervention. If we can catch them there, it's integrated with daily life. So it's Monday through Friday. They come, it's like a school day, and then they go home at night. And so one of the things that's wonderful about that is that they can practice their skills. So they can talk about real life stuff, and then they go home, and then the next day in therapy they can say, how did it go when you were with your brother last night? Were you able to stay calm? Were you able to do that thing we talked about? Were you able to do your self-care task we talked about? Whatever it is that they have been working on. And so it's really integrated with real life in an important way. So for some folks who have been some suicidal thoughts, but they don't have a plan and they have a good support system at home, so parents or guardians, whoever is watching them, that are involved and able to kind of keep an eye on them, and you feel this is a pretty safe environment, they might be appropriate for partial. And you don't have to be the expert, again, at knowing what level of care. We have social workers in our contact center who can do this assessing to figure out. So if you're not sure, that is totally okay. This is just can be helpful to kind of get the lay of the land. But we have people who do this every day, all day as their job. And so you, again, don't need to know all the details, but hopefully it's helpful to just get an idea of it. So then we have inpatient, and honestly, the content of inpatient and partial are very similar during the day, but inpatient is for folks who really need that 24/7 care to be safe. So they're having more concrete suicidal plans, or maybe they've attempted And we see some folks with psychosis. So if they're having kind of their first psychotic episode, that would be the place that they would typically go for inpatient. So if you think somebody needs outpatient services, there are a couple ways to refer. And one, I think probably the most common way that you guys are doing it is to tell them, that you recommend therapy and maybe give them a phone number to call. That is a fine way to do things. And I have cards that I can give you. So take note, at the end is my email, and you can email me if there's any materials that you would like, but we do have cards that have our phone numbers and stuff on them. So certainly I'm happy to send you a stack of those cards that you can give out to families. And that's, again, those seed planting moments. If they're like, I'm not up for it, but I'll think about it, that's a good time to give a card. What I really prefer, though, is this outpatient referral form, and this is found on our website. The links are at the end of the presentation, but it's pinerest.org/partners. It's right there too. And this form, you would have to have the parent fill out. So you'd have to, coordinate with the parent to fill out this form, but they could print it off and, coordinate with you. So, but if you send in this form, then the ball's in our court. So then we will call the family to set up that meeting and talk with the parent and schedule that. I always think when a family is really struggling and they're kind of feeling in over their heads and overwhelmed with what's going on, it can be a lot to pick up the phone and call. And I think the stigma, again, really prevents people from making that call. We see it all the time where somebody is kind of like convinced to go, and then they go home and their spouse says, "Why, you don't need to go to therapy? Why are you doing that?" So we want to make it as similar to any other referral that, like a primary care doc would do to anybody else. We want to kind of make it like that. Like, this is what is going on, and this is how we treat that. And I'd like to make that referral. So hopefully that's some helpful language. So this is information about our these are some pictures of our adolescent partial program. So this is that day program, Monday through Friday program. And this is not locked. So the kids have to be reliable to stay there. They have to want to be there at some level, right? And you can see here, these are some of our group rooms, and they have lunch together here. And they're going to meet with a psychiatrist. They'll have a case manager, and there's a whole lot of groups and classes. The next slide I'll show you. Here they have, these are just a variety. This is just a sample. So this isn't what they have every day. This is one particular day of the month. It's a rotating schedule. But this is very similar, like I said, to what would happen on the unit as well for inpatient. So you can see they have group therapy every day, and that would be with a social worker. And then we have activity therapists who do a lot of sort of educational teaching them about sort of the more medical side, pharmacology. They'll do activities with them like yoga, teaching them mindfulness, how do you handle stress, coping strategies, those kinds of things. And then we also coordinate with families, of course, for these. So I'm going to hop off here a second and share. This is a video, and it didn't load on here very well, so I'm going to do it a different way. So hopefully you can hear this.
Walking through the door at Pine Rest might make you feel a little anxious, but don't be. You and
Hold
your
on one second.
Walking through the door at Pine Rest might make you feel a little anxious, but don't be. You and your family will be welcomed with understanding and treated with excellent care.
Welcome to Pine Rest. My name is Sally. How may I help you?
Hi, Sally. I'm here to receive services for my spouse.
Okay, why don't you follow me into the contact center, please?
Okay.
This is Clint. He is our safety specialist, and he will bring you into an interview room.
Hi, welcome. My name is Clint, as Sally said. Glad you could make it safely. Charles, Lisa, if you guys can follow me, we'll get you started into an intake room. folks can have a seat right in here. I do have to ask, do you have anything in your belongings that may harm yourself or anybody else while you're here?
No, I put everything in the locker.
Okay, thank you, sir. Rhonda, our clinician, will be in shortly to see you, and she'll take great care of you.
Thank you.
Good morning, Lisa, Charles. My name is Rhonda.
Hello.
I'm a clinician here at Pine Rest. I'm just going to ask you a few questions, gather some information from you, and then we'll try to figure out how we can best help you today.
The staff at Pine Rest will guide you through every step of the process here on the inpatient unit. It's a secure environment for your safety. They'll tell you what to expect for your individualized care. Although each person's length of stay is unique, the average stay is 9 days.
Hi, welcome to the unit. My name's Maria. I'm going to be your psychiatric technician today. We're going to go onto the unit and do the admission process. During the process, we will take your blood pressure, take your temperature, go through your belongings to make sure you can have everything, and do some paperwork. This is going to be the room that we are in, so if you want to head on in and get comfortable, you can answer any questions that you have today about being here. Okay. Another part of the admission process is to go through your belongings. We will go through them together today. Most of the stuff you are able to have. There are a few things for your safety that we will store for you while you are here, such as strings, razor blades, and belts. They will go in a bin, and then upon discharge, you will get them back. Your nurse is going to be Jamie. She's going to finish up the admission process. She's great. If you have any questions or need anything, feel free to ask her. Do you need anything before I go?
No, thank you.
All right, I will go get Jamie. It was nice meeting you.
Hi, my name's Jamie. I'm one of the nurses on the unit. I'm going to be working with you on the admission process today. We're going to talk a little bit about what brought you to Pine Rest, the things that led up to you coming here. We'll talk about what you can expect during your length of stay. We'll talk about the psychiatrist and what's going to happen. And if you have any questions at any point in time, please let me know, and then we'll end with the tour of the unit. This is our whiteboard. This is updated daily. It'll show you where you need to be and when. So if you ever have any problems or questions, you can come out here and look. This also tells you who your nurse is and what groups you're going to be into. That way you know who to go to if you have any questions and where you're supposed to be. Up here on our right-hand side, this is our lounge area. This is where people can hang out. We have lots of games that you can play, coloring, snacks. This is also where your family and friends can come and visit you during visiting hours. And then up here on our right, we have our TV area. This is available when groups are in session. You're welcome to come out here, hang out, watch your favorite shows. And then we're gonna go ahead and step up here. This is one of my favorite features. This is our sensory room. It's a feature that's unique to Pine Rest. We have our bubble tubes, mood lighting, aromatherapy. It's a great place to come and relax and unwind if you're having a hard time or if you just need to sit down and talk to someone. Just let any staff member know and we'll be happy to come in here with you. We do have our courtyard. We have lots of activities and games. We try to get out as often as we can in the beautiful sunshine. And then right up here on our left is our quiet lounge. If you don't like what's on TV out here, if you want to have a nice place to come and read, somewhere to relax and unwind that isn't necessarily around everyone else, this is a great place to do so. And then I'll show you to your room. It's right this way. This one is yours. You do have a private bathroom in this room. And then we also have a great little nook for you to sit in and enjoy the nature out your window. This is your treatment team. This is who's going to be helping you with your stay while you're here. We have Dr. Coleman as your psychiatrist. I'm your nurse, Jamie. Amy will be your case manager, and Charles is the psych tech. This will be updated daily, and if you have any questions or problems throughout your stay, please feel free to come to any one of us and ask.
Each and every day of your stay, your treatment team will be there to help you on the way to recovery. Each day, you'll have about 6 hours of program activities.
Hi,
I'm Dr. Coleman. I'm a psychiatrist, and I'll be working with you while you're here at Pine Rest. If you have a few minutes, I wanted to spend some time talking to you, getting to know you a little. Let's go in this interview room here if we could. You can go and have a seat right over there. Okay. Like I said, I'm Dr. Coleman. I'm a psychiatrist, and while you're here at Pine Rest, I'll be working with you pretty much every day. I'll see you. Only exception would be if I'm working on the week. If I'm not working on the weekend, I'll have one of my colleagues see you. So they're usually pretty nice people too. So don't worry about that. Did you need anything before we get started?
No, thank you.
Okay. Well, this is going to take about 30 to 45 minutes. Okay, and what I want to do is just spend time getting to know you, not just what happened to bring you in the hospital, but really who you are, how things are going at school or at home with your job and things like that. Okay, so if you're ready, we'll go ahead and get started.
Healing is possible, and your stay at Pine Rest is the first step. And when you leave, rest assured Pine Rest will still be here to help you as you transition back home and maintain better mental health day after day.
So I hope that was helpful as an overview of what it is like for folks when they come. I think that can be a helpful video to show a child or a family if you know they're going to be coming our way for the hospital. That would be a pretty similar process for both partial and inpatient hospitalization. And don't you just love Dr. Coleman and that bright pink shirt? It makes me laugh every time. That guy is so nice. All right, so these pictures are of our child and adolescent unit. We actually have 2 units for kids. One is our child and adolescent unit, and this unit is sort of split into 2 wings. So there's kind of different programming and different space for the younger kids, and then the sort of young teens. You can see here there's some beautiful colors and bright child-friendly sort of paintings on the walls and things like that. We have a sensory room on this unit as well. Like you saw on the video, there's an outdoor courtyard. And one thing to think about is just that I think when people think of a hospital, they think of people being in a bed all day. And obviously our hospital is pretty different than that. Part of the treatment model is to be in groups. So most of the day is spent in groups with peers. And so it's not that picture of being at a hospital in your bed all day. It's really the opposite. They are not in their room very much, just maybe during some free time and in the beginning and the end of the day. And most rooms are single rooms. There are some that are shared, and we are able to use that pretty strategically. You know, we'll have some kids who share a room at home and are scared to sleep alone in a room. So it's good to have kind of that combination of both options. So this is Cypress. This is the unit that you saw in the video. This is one of our newest units. And you can see kind of the green chairs in the upper picture. That's where they have meals together. And then you can see one of the group rooms, quiet lounge down in the bottom. And there's some nice things that they included in this unit as well. There's kind of a get ready space. And so I like that because, you know, for safety, there's a lot of things that teens are used to using that they can't have. So for example, a lot of the girls will use that get ready space. It's right by the nurse's station. So there's mirrors that are made out of a material that's not glass. So it's secure for a psych unit. And then the staff can keep blow dryers or hair straighteners, things like that for kids there. And then they can borrow them and use them to get ready. Makeup as well, they can't have in their room, but if they want to have it kept by the nurse's station, then if they want to get ready and kind of do their normal thing and feel as normal as possible inside this space, that can be really helpful. So that's a neat thing that they added. So this unit has 2 sections as well. And this one distinctly has different ways that it can be divided up. And so it was really neat how it was created so that it can swing based on the community's need for adult beds or kid beds. And so typically though, half is, or part of it is for 16 and 17-year-olds. And then the other part is for 18 to 25-year-olds. So they are split. There's a locked door in between the two. But we're able to move the numbers around a little bit based on how many teens we have a need for at the time and how many young adults we have a need for. And there have been times where we have swung the whole thing for teens when the community need is really large. And the other way, we've had months like in the summertime, numbers for kids seem to be really low and numbers for adults often go up. So then if we need to, we can swing it for adults. So that's been really helpful to be able to do that. We also have a media room on this unit where they can use computers and things like that as part of what they're doing for their treatment. And again, a courtyard and sensory room. They're working with a multidisciplinary team. I think you get that sense from the video. A lot of different staff. So if you have a student who needs hospitalization, these are the numbers you can call. It's the same place. It's just one is a 616 and one is an 800 number. So at the contact center, we've got social workers and nurses, and they will help assess if this is a appropriate placement for inpatient or maybe partial, or sometimes they end up, sending someone to therapy instead of a hospital. Now, I do want to make a note that if the person has Medicaid or no insurance, they do have to go through their community mental health. So that can be tricky sometimes. We do recommend that you call first rather than just sending a family. Again, our psych urgent care right now is just for adults. And there are times where we are, struggling to find an appropriate bed for someone because of our numbers. We have people coming in and people leaving every day, and that demand fluctuates a bit. So we, we don't want to have somebody show up and then have to turn them away and say, actually, you should be going to therapy, or we don't have an appropriate bed today for you, that kind of thing. So a phone call is always helpful, and that can be with you, but usually that's with the parent calling. If you have a kid and you see them and you're really concerned about them, and you're going to recommend that the parent call, you can also give us a call at that same number, and that can be really helpful. You can share what you saw, what you're worried about, because that can help make that case for insurance to cover it. Because oftentimes what they'll tell you, who they know and trust, is very different than what they'll tell our clinicians who they haven't met before. So it can be really helpful to get that bigger picture if you can share information that you have with us. Don't assume they'll tell us the same thing that they tell you. So please pick up the phone and call us. You can also three-way. So if you're talking with a parent and you're recommending hospitalization, consider calling us at the hospital with the parent on the phone and doing that kind of warm handoff. That can be helpful. So a couple of resources here. We have a web page that's really specifically for our community partners, and that's pinerest.org/partners, and that's where that video is. So if you go under the hospital link, and there's all kinds of other information, that's the same page that the referral form is on. We have a community partner newsletter, which we created a couple of years ago to help keep our friends and colleagues from other places up to date about what's happening. So when we opened the special care unit for COVID for adults, for example, we communicated it through there. We also communicate about our many trainings that we have through that. So to sign up for that, you just go to pinerest.org/partners news. So we have a Pearls for Partners series, which is sort of my baby. It's something we created several years ago, and it's opportunity for free CMEs and CEUs if you need those. And I just wanted to note that the March 24 lecture is going to be called Too Many Hurting Kids, Suicide Risk Assessment with Children and Adolescents. So that might be something that you would be interested in. And again, that's free. And right now those are all online. So pretty easy regardless of where you live. Registration's not live quite yet for that, but it should be probably in the next week. So, and then lastly, youth mental health first aid is something that kind of the county mental health foundation and Kent ISD do. And that's a wonderful resource. If you haven't done it and you want to learn more about working with kids, that would be a wonderful resource. So,
Lindsay, do you currently have any beds open?
oh boy, today I can't tell you because I skipped the 11 a.m. meeting because it was right before this. So I was like, I'm not going to log into that and be in 2 meetings at once. So I can't tell you exactly where we're at. We have discharges every single day. I know we've had very high census, but typically there are discharges every day. So it can depend on, what time of the day you call and what the actual blend is that particular day. But I mean, it's a rolling thing. Like if you called today and there wasn't a spot, 2 days from now, there could be, because there are people that are leaving every day. So it's a little bit of a moving target in terms of answering that question.
Thank you. We had our participant ask, so I wanted to get that real quick before you went on.
Yeah, good question. So yes, and now is the moment for other questions. I hope that this was helpful. And if you have comments as well, experiences or things that you want to share that you think might be helpful, I'm open to whatever.
Everyone in this group you are all have availability to unmute, unlike the first session. So if any of you want to ask, you don't need to wait. You can go ahead and unmute and ask a question.
Great, and feel free to use the chat as well. I had a colleague who worked with schools for several years, and she's no longer at Pine Rest. So this is my first presentation to this population. I'd love to hear if it was helpful, if it was on target for the things that you were hoping to learn today, just in terms of my future presentations.
I think the one thing that's most helpful for us is to learn about the insurance part, because that's really what keeps families away. And then usually when all the beds are full in the county, we usually just send them to the children's hospital, which is also expensive. And so I think at least I can speak for my population, our biggest thing is finding beds, seeing if their insurance, and then getting the parents on board. And then kind of like when the parents are like, listen, you got a roof over your head and food on the table, you're fine, but we're like, no, like we're legit concerned that they're going to hurt themselves. Like they need to go somewhere. At what point do you call like a wellness visit or a CPS or?
Yeah, and I think those are really good questions. I think you're asking the right questions. And I would think that doing that in consultation with peers or colleagues is always, I'm sure, what you're doing and is helpful. You can always call and talk to our social workers. So even if you can't give identifying information, but you're like, here's my case, what do I do? This is what I'm hearing. This is what I'm concerned about. What should I do? And they can say, they can give you direction on that. So that's a really nice kind of free resource you can have at the ready to talk to one of those social workers who are doing that assessment every day. And they, who knows what they'll say depending on the circumstance, but they can give you some really good guidance. And it kind of gives you a, phone a friend of like, it can be hard, especially when you're in the moment, even if you're an experienced clinician, to go, okay, I got to do the program. I got to work all the things I've learned. Right. And so that can be a really helpful thing to just call them and talk to them. But yeah, it is really hard to get the buy-in, especially when you're talking that, when it gets to inpatient, that's like a really different scenario, right? But when you're like, this kid is really struggling, we hear all the time that parents don't want to take their kid out of school to do partial. And I always think like, well, how much school are they getting when they're there anyway? If they need that level of care, they're probably not getting much out of school anyway, even if they're physically in the building or physically online or whatever they're doing for school, they're not it. So I always say, 5 to 10 days in this program might sound like a lot, but when you talk about if they can, our research shows 5 days in a partial program, moves them down a level in PHQ score. So that is huge. 5 days. I mean, what else no med can do that, right? Like, I mean, we use meds too, but in itself alone, 5 days isn't enough for most of our meds for mental health disorders to work. So 5 days is amazing to be able to function that much more. And so you think about, wow, well, that's a big impact, and that gets somebody better more quickly. And then all that they're going to be able to engage with and gain in both social and emotional, but also academic, is just, yeah. So, but also avoiding that inpatient stay, right? Like, from my experience, if we don't address it now, in 3 to 6 months, we'll probably be looking at an inpatient stay. I hate to tell you that, but your kid is really struggling, and we can choose to address it now at a lower level of care, or we can wait, but it will likely end up in a inpatient stay. So that's your choice, you know, because those lower levels of care are of course optional. So
Thank you.
yeah, I hope it's helpful. And you guys can keep my number too. I am part-time, so if I don't respond right away, that's why, but you're welcome to email me if you're kind of like, okay, what do I do here? You know, if it's sort of like, I did the things you said, now what? But if it's a more in the time moment, I would call the contact center. Anything else? Well, thank you.
Thank you, Lindsay. And for the rest of the group, we have a small break before our end keynote speaker. So we have a small lunch break, and then you'll log back into the keynote for the last session of the day, which we'll all be in. And there will be raffles after that. And Lindsay, thank you so much for all of the information. And we will make certain that if anyone needs some of your resources, we'll get those to them. And we've also recorded, so this will be available for others to view at a time that may be more convenient to them.
Good. That sounds good. Thank you very much, everyone. I'm glad I see in the chat it was helpful. Thank you for the feedback. Have a good day.